Let us look at the anatomy of the skin, right? The skin consists of 3 layers: the connective tissue layer, the dermis, as well as the epidermis. The function of the skin is to act as the first line of defense against microbial invasion. As you may or may not know, the skin undergoes continual epithelial cell turnover, thus removing substances as well as potentially pathogenic microorganisms on its surface. Now let's talk about streptococcal skin infections. The first streptococcal skin infection that we will be talking about is impetigo. Impetigo is a pyoderma, meaning that it is caused by pus-forming bacteria. Impetigo is caused by group A streptococcal, and most commonly. And occasionally, it can be caused by group B streptococci, especially in newborn babies. The lesion of the impetigo initially begins as small vesicles that pustulates and rupture, creating a thick, yellow, and encrusted appearance, as you can see in this picture. The impetigo lesions are superficial, and they are not painful, and they itch a lot. They spread easily by scratching, and impetigo is common in hot and humid climates, and it is highly contagious. So prompt treatment of this condition is very, very important in order to prevent immune complex-related glomerulonephritis in children and infants. Remember, post-streptococcal familial nephritis. The next skin condition that we will be talking about is erysipelas. Erysipelas is a skin infection that is caused by group A strep and sometimes by group B strep, group C strep, and group G streptococci. It is a deeper form of cellulitis. It involves the superficial epidermis, underlying dermis, and lymphatic channels. So it's quite extensive if you compare it to impetigo. It's characterized by a painful indurated area of cellulitis with raised, sharply demarcated border and has a typical crimson hue. Uncomplicated cases remain confined to the dermis and lymphatic channels. Complicated cases, however, may spread to the bloodstream, causing bacteremia. It's important to note that erysipelas has a strong liking or predilection for the face, and to a lesser extent the lower extremities, as you may have seen in the previous page. Most cases are caused by group A strep, as I've already alluded. It's important to note that in some cases, the infections can be caused by group B strep or group C strep, even group G. The third skin infection caused by streptococci that we will be talking about is cellulitis. Cellulitis is an acute spreading infection of the skin that extends deeper than erysipelas and involves subcutaneous tissues. How does the lesion of cellulitis look like? The cellulitis lesions are ill-defined. They're flat and painful. They are also red and swollen. The patient may have fever, chills, and they may feel tired, meaning that they have malaise, as we say in medical terms, and a regional lymphadenopathy may develop. So, cellulitis can be caused by streptococci, and the streptococci that cause cellulitis are the group A streptococci. Do remember that cellulitis can also be caused by Staphylococcus aureus. Cellulitis caused by group A streptococci may manifest within 6 to 48 hours in post-op wound infections. Hypertension, often caused by bacteremia, may be the initial sign of infection. A thin serous discharge may be expressed on compression of the wound margins, and streptococci can be identified on gram stain and culture of the fluid. Scarlet fever is caused by a group A streptococci that produce an erythrogenic toxin. It may be associated with the sore throat or wound infection. Also, skin or pubic infection, as well as erythroedema, and a strawberry tongue with prominent papillae. The rash appears on the neck, the chest, as well as the skin fold, and it has a sandpaper texture and is bright red, as you can see in this picture. The rash disappears after 5 to 7 days, followed by disformation. The rash does not involve the face, but there is flushing of the skin and circumoral pallor, as you can see in this picture. During convalescence, this formation of the skin occurs, especially on the feet or hands. Eczema is another infection which is caused by group A streptococci. The lesion of eczema begins similar to the lesion of impetigo. However, the only difference is that the lesion of eczema penetrates deep into the dermis. It frequently occurs in the lower extremities, in children and the elderly. It consists of a punched out ulcer, which is covered by yellow crusts. It's covered by yellow crusts that extend into the dermis and are surrounded by violaceous margins. As you can see, there's a purple margins. Necrotizing fasciitis. Necrotizing fasciitis is an invasive infection characterized by rapidly progressive inflammation and necrosis of the skin, and subcutaneous fat and fascia. It's uncommon, but it's life-threatening. It is caused by group A streptococci. The group A streptococci are also called flesh-eating bacteria. Necrotizing fasciitis can be categorized into 3 types. Type 2 necrotizing fasciitis consists of only group A streptococci. Streptococcal gangrene is a rare form of gangrene caused by group A, C, or G streptococci. Usually develops at the site of trauma on an extremity. However, it may occur in the absence of any portal of entry. The lesion begins as a painful area of erythema, meaning an area of redness, and then it becomes a dermatitis. The extent of this aggressive process may be initially underestimated because it spreads widely in deep fascial planes with a relative sparing of the overlying skin. Streptococcal toxic shock syndrome may evolve rapidly and become the most prominent feature. Over a period of 1 to 2 days, the skin becomes dusky, and the bullae containing yellow to red fluid develop and rupture. The lesion develops into a sharply demarcated area covered by necrotic fascia and surrounded by a border of erythema, thus resembling a third-degree vein. Bacteremia, metastatic abscesses, and death may result if not promptly treated. Secondary thrombophlebitis maybe a complication if lower extremities are involved. Now, let's talk about gas gangrene. Gas gangrene is a Clostridia myonecrosis. It can be classified as necrotizing fasciitis type 3. Remember what I've said previously. Type 2 necrotizing fasciitis is caused by streptococci. So now back to gas gangrene. It is caused by histotoxic Clostridia, which include Clostridium septicum, Clostridium perfringens, Clostridium novii, Clostridium histolyticum, and Clostridium pseudonii. Histotoxic Clostridia are anaerobic, gram-positive, spore-forming bacilli, which are found in the soil. They are also part of the normal flora of the large intestines. They are transmitted by contamination of the injured tissue. So when one is injured, the spores from the soil can contaminate the wound. It's either the spores from the soil or the gastrointestinal tract. For myonecrosis to develop, a lower oxidation reduction potential must be present. How does that happen? The low potential is due to a reduction in pH, due to a reduction of pyruvate to lactate, and is due to usual tissue trauma, surgery, or ischemia. The clinical manifestations of myonecrosis include severe pain in the affected area, edema, cellulitis, gas production, foul smelling, purulent discharge with gas bubbles, crepitus, as well as tense blebs containing thin serosanguinous fluid or dark fluid in the overlying skin. Tissue death may ensue. The patient may have fever, tachycardia, as well as hypertension. Now let us take a look at staphylococcal skin infections. Staphylococci, like streptococci, do cause primary pyodermas. And the primary pyodermas caused by staphylococci include impetigo, folliculitis, pharanthinosis, carbuncles, and paronychia. We will touch either on these individual pyodermas in the upcoming sections. In addition to primary pyodermas, staphylococci also cause secondary bacterial skin infections, such as surgical wound infection, intravenous site infections, hidradenitis suppurativa, which is a chronic skin infection presenting with lumps in the groin or armpits. Staphylococci also cause skin manifestations secondary to toxin production. And the toxins responsible are the staphylococcal scarlet skin syndrome toxin, as well as the staphylococcal toxic shock syndrome toxin. Let's now look at the primary pyodermas that are caused by staphylococci. The first pyoderma that we will be talking about is bullous impetigo. Bullous impetigo is a skin infection caused by Staphylococcus aureus. It is only the Staphylococcus aureus strain that harbor a phage group 2 that produce an exfoliative or an epidermolytic toxin. So this particular toxin is the one that is responsible for bullous impetigo. Phage group 2 strains of Staphylococcus aureus contain genes coding for the exfoliative toxin. So in other words, the Staphylococcus aureus strains that do not harbor the phage group 2 do not cause bullous impetigo. So now let us look at the lesion of bullous impetigo, right? The lesion of bullous impetigo is localized, and it's discrete and with thin walls, and it looks like a blister. And this blister contains a clear yellow fluid. And when this blisters rupture, they try to form a transparent, varnish-like cast. This should remind you of a bullous impetigo caused by streptococcal as well. Staphylococcal bullous impetigo is a contagious disease. It often affects unawake children. It can appear in any parts of the body, but it occurs mostly on the face, the arms, and the legs. It also occurs in adults. And within adults, impetigo can occur after other skin diseases. Now let us look at folliculitis. Folliculitis is also a primary pyoderma that is caused by Staphylococcus aureus. Folliculitis is the inflammation and infection of the hair follicles. Our folliculitis is more likely to occur in nasal staph carriers, diabetics, those with dermatitis, obese patients, patients who are using steroid treatment, as well as those with lowered immunity. Now, let us look at the lesion of folliculitis. The lesions of folliculitis appear as small erythematous papules. As you can see, these papules look a bit red, and they also evolve to form pustules. And these pustules have a whitish or yellowish center zone, as you can see in this picture. The inflamed follicles may burst and release pus and cast over. The skin in superficial folliculitis is itching and tender, while in deep folliculitis, it may be painful. The common sites for folliculitis include the points of friction, such as the hips, the buttocks, the axilla, and the scalp. If folliculitis occurs within the ear canal, it causes otitis externa. And in this case, scarring rarely occurs. Let me just explain a few things. Superficial folliculitis affects only the upper parts of the hair follicle, while deep folliculitis affects the whole hair follicle. There are three different types of folliculitis. The first one that we will discuss is psychosis bilay. Psychosis bilay is a deep folliculitis. Remember what I said in the previous page? Deep folliculitis affects the whole hair follicle. So psychosis bilay is a deep folliculitis of the bearded area in men and involves the deeper parts of the hair follicles. And psychosis bilay may leave scars, remember that. The second type of folliculitis is a stye. A stye is an inflammation or infection of a hair follicle on the eyelid, as you can see on this picture. Untreated folliculitis can lead to complications. These complications include formation of furuncles. Furuncles are boils. It can also lead to cellulitis. Cellulitis is the inflammation of the deeper layers of the skin. Scarring can also occur, as well as hyperpigmentation. The patient may also experience permanent hair loss or alopecia. As I've already explained, if folliculitis is not treated properly, complications may occur. And one of the complications that I've already mentioned is formation of boils or furuncles. The lesion of folliculitis may develop into a deeper inflammatory nodule, as you can see in this picture. This inflammatory nodule is called a furuncle or a boil in simpler terms. The furuncles are initially red and thin, but soon become painful and fluctuant. The area that surrounds this bump may also be swollen and inflamed. And this bump is filled with pus. So that is why I said it's a boil. Boil is a furuncle. The furuncles generally drain spontaneously. Furunculosis can occur anywhere on the areas where there is hair in the body. However, the most common areas are the face, the neck, the arms, the armpits, and the buttocks. A furuncle may complicate and form a carbuncle. A carbuncle is an abscess that extends deeply into the subcutaneous fat. It may have multiple draining sites, as you can see in this picture. The patient may have fever, chills, malaise. The carbuncles commonly occur in the nape of the neck, as well as the back of the thighs. Staphylococci also cause paronychia. It's important to explain that acute paronychia is usually caused by staphylococci. Other bacteria may cause paronychia as well, so are the herpes viruses. Chronic paronychia, on the other hand, is usually caused by fungi. We will be focusing on paronychia that is caused by staphylococci. Paronychia is the infection of the cuticle surrounding the nail bed. Cases occur following minor trauma, such as removing a hangnail, and those who bite their nails, finger sucking, wearing artificial nails, and ingrown toenails. It may occur in patients who have wet hands constantly, like the bartenders or the dentist. The involved part of the nail may become warm, painful, and red. Swelling may occur, and in other instances, the lesion may become purulent, and pus may be expressed around the nail bed. Hidradenitis suppurativa. These are boils appearing in the armpits, the groin, the anal area, and under the breast and the inner thighs. It's associated with the genetic defects of the apocrine sweat glands. The hair follicles in this condition may then be infected by staphylococci, or the streptococci, as well as the anaerobes. So staphylococci as well cause infection in patients with this condition. Let's now discuss the staphylococcal scarlet skin infection. The staphylococcal scarlet skin infection is caused by an exfoliative toxin or epidermolytic toxin, which is released by Staphylococcus aureus, which harbors a phage group 2, as I have already explained. It occurs mostly in the newborns and in children under the age of 5. In this disease, the connections between the skin cells are cleaved by the toxin, resulting in scalding. The disease may start as the common staphylococcal skin infection, like impetigo, and then progress. The severity of the disease varies from being localized in the form of a bullous impetigo to a more extensive condition. Bullous impetigo may progress to a generalized form, which is characterized by cutaneous erythema, followed by a profuse peeling of the epidermal layer. So as you can see in this picture, there is actually exfoliation of the skin. The typical pattern in which erythema occurs is as follows. The erythema starts from the face and then to the neck, the axilla, and the groin, and then extends to the trunk and extremities. The duration of the disease is quite brief. It takes about 2 to 4 days. And the good thing is that the children recover spontaneously. And the toxin is metabolized. Listen to this. The toxin is metabolized and excreted by the kidneys. And it is believed that this is the reason why the disease is higher among children younger than the age of 5 and in adults with chronic renal failure and impaired immune systems. The staphylococcal toxic shock syndrome is associated with the staphylococci, which produce the toxic shock syndrome toxin 1, which is absorbed through the vaginal mucosa or skin in the non-menstruating type of staphylococcal toxic shock syndrome. So, the staphylococcal toxic shock syndrome is a rare but fatal multisystem disease. There are 2 categories of toxic shock syndrome. The first one is the menstruating type, and the second one, the non-menstruating type. The non-menstruating type is associated with any staphylococcal infection, but is more common in the post-surgical skin infections and secondary to influenza virus infections as well. The staphylococcal toxic shock syndrome results from localized infection by a Staphylococcus aureus, which produces a toxic shock syndrome toxin type 1, as I've already explained. The initial presentation is high fever, the rash, and signs of dehydration. In extreme rare cases, patients may be severely hypotensive and in shock. The rash is found predominantly on the trunk, but can spread over the entire body. The laboratory findings include elevated white cell counts, decreased platelets, and increased blood urea nitrogen, and DIC is likely to occur.